Lucy and Sarah, thank you for joining us today.
Thank you, Anne. Sarah and I are humbled and eager to be able to present this content today, especially as we close out a month of ethics-related activities, the fantastic bulletin content that we received this month, and we want to thank everyone in advance for joining us. We also want to remind everyone that the concepts in this webinar today are geared towards the entry-level professional. We're really hopeful, though, that any level of professional joining us this afternoon will gain information and enjoy our webinar. So thanks again for being here. As Anne said, we will be asking all audience members to utilize the chat box on several occasions throughout the webinar. We encourage you ahead of time to participate alongside us. To review our objectives today, at the conclusion of the webinar, participants will be familiar with the Child Life Code of Ethics, able to recognize ethical dilemmas, and able to articulate the rationale for why having a proficiency in ethics is critical in child life practice. For pediatric healthcare professionals, the goal is clear. It's to provide the best possible care for children and families. But when we're working with a premature infant who's on the borderline of vitality, or a toddler whose treatment might lead to a life of conditions that are very complex, or a teen who's had a brain injury that's compromised their brain function, the definition of what's best can be really murky. And that can be further complicated by individual patient and family values, cultural expectations, the access to treatment that a patient may or may not have, as well as intense emotions. Looks like some people are able to hear us and some people are not, but Anne's giving some guidance there in the chat box. Thank you, Anne. So moving on to our slide, Child Life Code of Ethics. The Association of Child Life Professionals has a long history in ensuring that its members have a code of ethics to abide by. The original Code of Ethical Responsibility was first approved in 1983. It was revised in 2000, and really in 2000 when it was revised, the intent then was to reflect the broader application of child life skills, mainly to areas beyond the hospital, such as private practice. And of course, the Code of Ethics has been revised again, and we'll talk more about that in just a few minutes. We do want to remind everyone of a recent change, though. Some of you may have already read this in the latest edition of the CCLS Connection. The name of the Code of Ethical Responsibility has officially been changed to the Child Life Code of Ethics.
Okay, so all CCLSs agree to abide by this Code of Ethics, which we attest to at the time of our certification, and then again every 5 years at recertification. Our profession is ultimately governed by these principles, which were specifically developed for the work that we as CCLSs do every day. These principles are different than the universal principles that we're going to talk about shortly. This Code of Ethics and the principles therein are in place to help guide the work of our profession. While our colleagues in social work or music therapy and even nursing will have similar guidelines for their respective profession, they all likely fall under the umbrella of the primary tenets of ethics, and we are going to talk more about those ethical tenets throughout this webinar.
Thank you, Sarah. This next slide represents a screenshot of the Child Life Code of Ethics, and we won't read this to you. However, we do want to point out that this document specifically states that as a CCLS, we are ethically responsible to children, youth, and families other professionals, so nurses, therapists, physicians, students and volunteers, and ourselves, personally outside of our work as a CCLS and professionally. The 13 principles in our code help guide us in our decision making. They also provide support to help us implement and practice our personal boundaries. And really, most importantly, they help to support us in providing the best care possible for our patients and families. It's critical for all certified child life specialists to have knowledge of the content of these principles, which guide our work in our profession. This not only protects patients and families, but it serves as protection for us. If you look at Principle 8, for example, this principle guides us to work only in areas that we are qualified and to make appropriate referrals when and as needed. Understanding the scope of our work and making referrals when needed not only protects us, but most importantly, it ensures that children are receiving the appropriate care. The Child Life Code of Ethics was recently revised in July of 2019. The Child Life Certification Commission, specifically the Ethics Committee, provides resources and education to membership about ethical practices and ensures that our Code of Ethics and other ethics resources specific to our profession are current in child life practice. We want to point out Principle 12 now, which includes the responsibility to teach ethical values to our students. I know that many internship programs have a lot of great module and other educational content for students related to ethics. And we're proud that our code encompasses the responsibility to train our students about ethical values early in their careers, as ethics is really the foundation of our practice. This slide has a picture of an illustrated overview of some of the universal ethical tenets. Ethics is a philosophical discipline. Unfortunately, it doesn't tell us what's right or wrong. That would be easy. But instead, what it does do is it helps us to articulate our theories about cases and situations. So ethical principles provide us with words. The ethical principles, or tenets, serve as foundations for our moral rules. They provide a rational structure when we're trying to make decisions. How to decide and who decides are the central questions when we think about ethical decisions in pediatrics. Several approaches have been used to identify and analyze ethical issues, especially in healthcare. The most popular approach, though, is the principlism approach, which is basically the application of ethical principles. We're going to dive deeper into some of these universal ethical principles now. A little interesting fact about the history of the autonomy principle. The history of the autonomy principle in medicine originated when healthcare delivery, especially in hospitals, was characterized as having two positions, a vertical position and a horizontal position. White-coated vertical physicians sit around the horizontally placed patient, talking with one another and making all of the decisions. It's noted that the early history of the bioethics movement actually began when someone decided that they needed to prop up the patient so he could participate in the discussion of his own healthcare needs. That really began the respect for autonomy of all those engaged in the discussion, and it led to a radically altered practice in medicine. If we look at beneficence in a little more detail, this principle refers to the duty to do good, the duty to promote welfare of the individual. And in healthcare, this principle includes the duty to maintain as well as restore health relieve symptoms, and ultimately maximize functionability. When I think about beneficence, one of the things I think a lot about is rehab medicine. The whole goal of rehab is to restore functionality, to help the individual gain back skills that were once there and might now be lost, or to help the patient learn skills to compensate for the loss of a skill. For example, an occupational therapist might work with a patient to help him or her gain strength in their right arm after an illness or injury has left their right arm weak.
So next we're going to move on to justice, which is also on this chart. And justice is really the duty to be fair and impartial and avoid discriminatory practices. And what this could look like, if someone is not acting with justice in mind, is avoiding or refusing to see patients who, and families who may have differing religious or cultural or moral values than you. It could be offering more services or resources to the child of a celebrity or of a hospital employee as opposed to other patients that are also on your floor. And then there's the always hot button topic of whether we attend patients' birthday parties outside of the hospital. And when I'm thinking of this, I always think of what my answer would be if a parent asks me, why did you go to Lucy's birthday party, but you didn't come to my child's birthday party? Or what I get a lot is, you gave our next door neighbor an iPad, but you didn't bring one to our room. Why did you do that? And if I just find that if I don't have a justified answer, or if I have to lie to the parent, that's just not something that I'm going to do. So that's justice. It's just being fair and impartial. And then next is fidelity. And fidelity is similar to veracity, which should be in the Making Ethical Decisions book and elsewhere. Fidelity is about promise keeping and being loyal to your word. So there's this classic example, as most of us learned in our internship, that we don't make promises we can't keep. We don't tell children that we're going to come back to their room at a certain time, or that we're going to come back, knowing that that might not happen. So you promise to go and you're going to come back and see a patient, you get pulled into something else, and then you can't make it, and that child will likely be upset. And I run into trouble with this myself. I have a patient who I've worked with for over 5 years. He's very smart. He's an only child, and he doesn't understand why I can't play with him during my entire shift. And so if I'm acting with fidelity, when he inevitably asks me, what hour and what minute are you going to come back, because that's what he does every time, I could say, or I would say, I don't know when I'm going to be able to come back and play next, but do you have everything you need until I'm able to make it back? So that is, I'm letting him know I'm going to come back, but I'm not making a promise. So we want to be mindful of making the promises that we can't keep. So using the chat box, this is just 4 and 5 of the ethical principles. If you can use your chat box and identify any other ethical principles or tenets that aren't listed on this slide, we'll take a couple of minutes and see what you guys enter and what ethical principles you are knowledgeable about. So, yes, I can repeat the question. So using the chat box, we talked about some of the ethical principles here, autonomy, beneficence, fidelity, but are there any other ones that you are familiar with that you utilize in your practice? Looks like people are still having trouble hearing. We'll give it a couple more seconds and we might just move on.
Sarah, do you see we have confidentiality there on the screen?
Yeah, we have, competence.
Perfect.
Yeah. Yeah, Facebook friend requests from patients and parents, use of touch, respect, justice, yeah. Uh-oh.
Those are great examples. So I'm seeing things like respect for persons, competence, confidentiality. Thank you for participating.
Yeah.
Just a note on emotional safety. I think that's something we've seen recently in our strategic plan and heard a bit about at conference, and I know we'll be hearing much more about that. But as we build on our foundational knowledge of ethics, and as our profession incorporates emotional safety into our strategic plan, I think all child life specialists will realize that ethics really is all about ensuring the safety of children and families. Whether that's emotional, physical, or spiritual safety, these things aren't mutually exclusive. Autonomy is about the patient being able to make decisions, and empowering children to take control of their own health care keeps them safe emotionally. Beneficence is about avoiding harm, avoiding emotional harm, which is really the very foundation of child life practice. Veracity includes telling the truth. We keep kids emotionally safe in the hospital when we provide preparation and developmentally appropriate information. In short, utilizing ethical principles, upholding our ethical principles, keeps kids safe from and mitigates the unintentional harm and trauma that can happen as a result of hospitalization. Thanks again for participating there in the chat box. We'll do that again with several other slides. As advocates, the CCLS must be able to recognize, evaluate, and then take action when they're faced with some kind of ethical dilemma or issue. The difficult part is that ethics has a lot of gray, and child life professionals must sometimes sometimes with some discomfort, as they and patients and families wrestle with decisions that are difficult. When this happens, or really all the time, we should always start with this question: what's best for the child? The tough cases, though, are the ones where there's really no clear answer, which is why it's really critical for child life specialists to have that foundational knowledge of ethics and to be able to build on that foundation, just as we build on all of our other skills throughout our careers. The gray zone, as we like to call it, is a unique challenge, and it's important that all of us as healthcare professionals help parents understand that they do have a choice, that they do have a voice. It's important for parents to understand the implications of the choices they're making and what should be considered to make the best decision for their child. If we talk about a CCLS working in a NICU, for instance, parents often who have a child in a NICU are facing decisions about life-sustaining treatment. Sometimes disagreements are happening. Sometimes doctors recommend treatments and parents refuse. Sometimes parents request continued treatment that a physician might think is not appropriate. Usually the dilemma comes down to questions about the value of a child's life when that child might ultimately have severe physical or cognitive impairments. We all have a personal commitment to uphold ethical principles. We've already talked about that several times throughout this webinar. And in any situation, the course of action chosen is expected to be consistent with the determined ethical principle. Just a note on ethical decisions and the Ethics Committee. In its primary role, the Ethics Committee of the CLCC is charged with evaluating and making recommendations regarding ethical concerns. The committee acts as an impartial review body to consider whether further actions are warranted once an ethics complaint has been filed. The course of action chosen, if any, has to represent a reasonable response to the nature of the violation. As we talked about a few minutes ago, the dominant theoretical approach to bioethics, in America at least today, relies on ethical principles, such as autonomy, beneficence, and justice. Some of those same concepts we discussed just a couple of slides ago. Most people are familiar with the principle-based approach, the approach that suggests that four principles, those four main principles, even though there's more, of autonomy, beneficence, non-maleficence, and justice, provide a framework that can help clinicians think through ethical dilemmas and then choose what the best solution might be. This principlism approach is helpful, and coupled with another approach, the QUAR framework, that we're going to talk about in just a minute, child life specialists and other professionals can gain confidence in working on ethics cases as well as making recommendations. Because ethics is gray, remember we have that gray zone, and especially in pediatric ethics, it's important to utilize a variety of approaches. Maybe we utilize principles, and maybe we utilize other frameworks as well. Because all of those things put together are going to help us make the best recommendation we can for families when faced with ethical dilemmas. Sarah and I really like this picture because it demonstrates the importance of working together, which is the point we'd like to talk about now. When making decisions, especially decisions that involve ethics, that really requires doctors, parents, and other healthcare professionals to work together, ultimately for the best interest of the patient and family. Medical advancements have really redefined the way doctors and patients address end-of-life or life-altering situations and decisions. Things that used to be fatal sometimes are no longer fatal. There's usually something more that can be done or something else that can be tried. That in itself is sometimes an ethical dilemma. If a ventilator isn't working, sometimes the child can be put on a lung bypass. The machine does the work, and then the lungs are no longer needed. We all know that dialysis can take over kidneys, and a left ventricle device can take over the heart functions. Much of this wasn't even possible 50 years ago. But knowing how far to push the limits is always difficult on families. And that often necessitates support from the psychosocial team, which is where we step in. We need to think of our own biases and opinions so that we empower ourselves to remember our role and our boundaries. These conversations are tough, and oftentimes families, especially after you've developed a rapport with the family, may ask, what would you do?
So right now, it's thinking about that scenario. If a family, when faced with a difficult decision, asks for your input, we want you to use your chat box and just type in some of the ethical principles the principles in the Child Life Code of Ethics that would influence how you would respond to this question. So we'll give you just a few minutes to type in. So we're asking, you were asked, what would you do by a family who has a difficult choice to make? And we want you to list the ethical principles or the Child Life Code of Ethics principles that would influence how you would respond. And while everyone's typing, Lucy had mentioned bias, and I think it's a good time to talk about just a quick mention of personal bias and how it influences our decisions and how it influences our responses. It's important to do what I call gut checks or self-checks and think about the things that would influence your decision. What is right for me is not necessarily what's right for you, and what's right for you may not necessarily be what's right or best for the patient and the family. So it's important to be able to separate our thoughts and feelings and our personal biases from the recommendations that we're making to patients and families during these difficult times, and even in not in the really difficult times, but just when they're asking for your opinion or anything that could influence how you would respond to a patient or a family. Okay. Oh, lots coming in. All right. Yeah, Principle 8, working within the scope. Principle 2, respecting religious and cultural beliefs. Lots of Principle 2. Somebody mentioned autonomy. Yeah, these are great. Principle 6, beneficence or maleficence, referrals for appropriate services, knowledgeable members of the multidisciplinary team, objectivity and staying within your scope, using reflective listening, and staying objective. These are all great, guys. Keeping your bias and opinions out of the conversation, that's a good one. Being a good listener. All right. Thanks, guys, for your responses on those.
Thank you. That's fantastic. Parents often confide in me that they don't want to tell the child about their new diagnosis. As child life specialists, we know this isn't right. However, talking with parents over and over again is exhausting, and it makes me think my own moral courage might waver. This is a quote by a child life specialist who was talking about working with patients and families and having many, many ethical issues arise in her practice. And it's really just an example of a scenario to get us started in thinking about how we encounter ethical dilemmas regularly, really on a daily basis. They may look different from this, but in our practice, we use our ethics to guide us on which patient we're going to see next, to guide us on how we're going to navigate our day. And as with any other medical professional, child life specialists are ethically responsible to patients and families. We know that. We also know that sometimes our profession can lead to exhaustion, which is a different topic than what we have going on today, but it's still important to think about creating the time, the space, and processes so that we can engage in ethical dialogue, because that's the right thing to do.
All right, we're going to go back to the chat box, and using this example, if you guys can tell us what the child life specialist who wrote this is faced with in this scenario, what they might be thinking about, ethical principles that are on their mind. Right. We've got patient and family beliefs as well as level of education about diagnosis. The patient and family will have personal biases, autonomy, respecting your service limitations, fidelity, principle 1 and 2. Principle 1, looking out for the best interests of the patient. Fidelity and truthfulness. Yeah, you guys have got it. So this is just another example of something that we face every day in our work. So looking at this slide, again, using the chat box, we all know the story of Pinocchio. What ethical principle does this picture represent? So we are thinking about Pinocchio and what his growing nose, what ethical principle that would be. Right, those are rolling in. We got fidelity and honesty, truthfulness, veracity. Lots of those coming in. You guys are right. So it's really veracity and fidelity, which is the obligation to be truthful. So this principle really mandates the responsibility to distinguish between what's right and wrong, and then to act accordingly. And how many times have we all been asked to not tell a child that they were going to have surgery, or my favorite is, I told them we were coming to get ice cream. So imagine if we did everything that parents wanted us to do in terms of what to tell children, our noses could potentially be as long as Pinocchio's.
Thanks, Sarah. Johnny's nurse just told me that Johnny is not going to be able to attend bingo tonight because he isn't being compliant with his medications and his treatment today. This is another ethical issue that a child life specialist recently worked through, and I'm sure many of us have had similar scenarios where a member of a nursing staff or the medical team sort of uses child life services as a reward. And so I think it's too often that we encounter scenarios similar to this. And this is really about the whole question that surrounds child life services as either a right or a privilege. And this slide really just represents the fact that having the ability in a situation like this, or in many of the situations we've talked about today, for the CCLS to be able to articulate a clear ethical position may then help the nurse or the other professional to understand this concept, to understand that child life services are probably ultimately not a privilege, but a right. We're going to shift gears just a little bit now to talk about another framework. So we've talked about using principlism, which is applying ethical principles to help us when we're having ethical issues or dilemmas. Now we're going to talk about a framework called the QUAR framework. And I want to make a disclosure that we are not promoting the QUAR framework as the only way to evaluate ethical cases. It's simply another tool that we can house in our toolbox. The contact information is listed on this slide because the certificate program in pediatric bioethics at the Children's Mercy Hospital takes credit for developing the QUAR framework. So why do we want to use a framework? We all know that sometimes when we get into a very stressful situation or a situation that leaves us with some uncertainty or some hesitancy, that sometimes we kind of get lost or stuck in the moment. And so when we use a framework, it helps to minimize that paralysis that might occur. It also offers an immediate plan or process, and it promotes some consistency. So if we use a framework in one case and we use that framework in the next case, it may help us to develop that solid foundation over time. That's not to say that all ethics cases aren't going to be different, because of course they are. But that framework oftentimes helps us to learn that language and to learn that process in order to work through the ethical case at hand. And as we discuss the framework, we will also discuss terms and phrases that are typically utilized when we evaluate ethical questions. When a child life specialist is equipped with the language, often he or she can then gain confidence that's needed to share space at the table, literally and figuratively, when we resolve ethical dilemmas. Child life is still a relatively young field, as we all know, and gaining proficiency in ethics takes time and practice, which includes learning the language of ethics. However, the good news is that all CCLSs are really well equipped to become proficient in ethics. Just look at all the information you guys are sharing in the chat box today. Looks like you're all very proficient in ethics already. But again, we're well equipped to become proficient in ethics, and we help patients and families navigate the unknown every day. We break down difficult language and familiar concepts routinely. The QUAR framework is really meant to be utilized by medical ethicists. However, we can all learn from it. Again, all of us are ready to put this framework into action. We all practice these skills whether we're in a hospital or other setting every day. We do this when we get to know patients and families, when we ask them questions about what they know, what they need, and then make a treatment plan. Using the framework and working on ethical cases is all about making an assessment, and that's something that all CCLSs are skilled at doing. So when we look at the QUAR framework, we'll go through each of the steps of QUAR. Q is question, U is understand, A is assess, and R is recommend. And then we sometimes throw in a take action, and we'll tell you a little bit more about that here in just a few minutes. The first step in looking at an ethics case is to ensure that everyone understands what the question is at hand. Most of the time, this is pretty clear. Most of the time when we're determining the question, we're maybe helping a parent determine whether or not to pursue treatment. Maybe they've already pursued treatment once and it failed, and they're trying to decide what to do next. Or maybe the question at hand is about discontinuing treatment. But again, most of the time the question is clear. Sometimes, however, it isn't as clear. And when Sarah presents her case in a little bit, she's actually going to explain how the question in her case was really focused on someone other than the patient. Regardless, though, of whatever the question is, whether the ethical question is in relationship to the patient or not, the patient is always in the center, and then there are other layers that are related to that patient. The first layer is patient-centered. That goes right along with our child life philosophy, right? It includes the patient, the parents, and when we're looking at ethics cases, it also includes the physician. The quotation marks around the word individual are in place just because although the question always surrounds the patient, in pediatrics anyway, the patient isn't always able to communicate their wants and needs or understand the situation. So that's when the parents step in, of course, or the caregivers. The second layer includes the interdisciplinary team, and it includes the extended family. For example, a mother and a father may already know what they want to do, or if and how they want to proceed with treatment. And then the grandparents might come to town and have other thoughts that influence that decision. And that's okay. That's primarily what happens. But that demonstrates that there's a second layer on top of that first layer. And the third layer is institutional. The hospital or the facility itself might have barriers related to the decision that the parents want to make and how to proceed. For example, the parents might want everything done, but maybe the facility doesn't have the appropriate equipment or resources to proceed with the next level of care. The fourth layer is societal. So looking at community, looking at culture, looking at politics. When you're working with a family who is Amish, for instance, it might not be up to the family or the institution or the individual at all to make the decision. It might be up to the community. And when I think about these layers, I think about Bronfenbrenner's ecological systems theory. Each layer interacts with and influences one another. It's also, to me, kind of like a SOAP note. Your S, O, A, and P have to align. If your subject doesn't match up with your plan, then there's a conflict about the assessment you've made for the patient. So all the layers are intertwined. The U stands for understand. This is when we gather basic medical and situational information. And this might seem pretty obvious. However, if you're working as an ethicist on a case or as part of the ethics committee, remember that you might not always be familiar with the child, the family, or the case. That seems kind of strange for us working as a CCLS. But again, we're talking about the QUAR framework in relationship to working as a medical ethicist. When we reach the assessment portion of QUAR, this is when we ask questions. And we think about how we phrase questions for the family. It's important to get to know the child and the family in order to best be able to evaluate the concerns in the case. For instance, mom might have very different concerns than what you anticipate, and a family's goals for the patient are likely to change throughout the course of the event. Remember that pediatric ethical cases are different than others because the child isn't usually able to make decisions in most cases. Sometimes, but many times they're not. They either don't have the cognitive ability to do that or they're much too young. So the principle of autonomy, a principle that's critical in resolving dilemmas that arise in the care of adults, is sometimes not as relevant in ethical dilemmas involving young children. Again, that just throws another layer into working in ethics in pediatrics. And then the R stands for recommend. So in this case, we're going to describe available options and offer as much specific guidance as possible. Remember, when we're talking about the QUAR framework, we're talking about this in terms of being a medical ethicist. And so a CCLS is usually not going to make the recommendation, at least regarding the ethics case itself, unless he or she is acting as the ethicist. However, a CCLS should definitely make recommendations within our scope, within our role, especially related to developmental and psychosocial information. A CCLS should also be empowered to take action. When Sarah describes her case, she's going to talk a little bit more about what taking action means. So we're going to shift gears a little bit now. Sarah is actually going to describe a case using the QUAR framework, and she'll talk us through these layers.
All right, thanks, Lucy. So before we get started, I'm going to present this case this is a case that myself and one of my coworkers worked on, and we were in a quandary. And so we're just going to go through each layer and each step of the QAR. So the first one, as we know, is the question. And the ultimate question at play here is this ethical? And I'm going to describe the situation in a minute, but is this situation ethical? And so these are the key players or the questions at stake, and we're going to go through each layer. So the first layer is obviously the individual, so that includes the patient, the parents, and as well as the medical team. I'm going to talk about it in one of the next slides. But the patient in this situation was not able to consent or make any, have any thoughts and feelings about what happened. There was also another family member who was, who this case really centers around. It was a 9-year-old relative of the patient. We're not really sure if he was an uncle or a cousin or what he was. But the case really centers around him and the patient. So the second layer is obviously myself, in addition to the bedside nursing team who are in the room providing the support to the patient, and then the chaplain who is also supporting the family. And both of those, both the nursing team and the chaplain, their opinions could influence the decision that a family or the medical team makes. The third layer is the institutional layer. And like Lucy said, sometimes there are hospital unit policies that are in place that affect the family's wants and wishes. And that is the case here. We had a policy in place. And then the fourth layer is the societal. This was a large Hispanic family who really described themselves as family-oriented. So there were lots of people involved, lots of conversations being had that could affect the parent's decision. So now we're going to go to the understand. So this is more of the background of the case. We know who's involved. And so what was happening is there was a 6-year-old who was now with little chance of curative interventions following multiple traumatic complications following cardiac palliation surgery. And if anybody's not familiar with cardiac palliation surgeries, those are just surgeries that are not curative, but they ease the symptom and the disease process that are really associated with congenital heart defects and his specific diagnosis. So this patient had recently received the last in a stage series of surgeries for his diagnosis. So for his diagnosis, there were 3 stages of the palliation surgery, and he had received the 3rd at an outside hospital before he came to our hospital. The parents had really demonstrated having a difficulty with acceptance and coping, and that looked like them avoiding the patient's room. They spent most of their time in the family lounge. They didn't go in the patient's room much at all. The mother had said on multiple occasions she was in shock. She couldn't believe what was happening, and she also wasn't ready to let him go. She wasn't ready to stop fighting for him. So we talked about, the parents are the decision makers and that there's lots of other family members involved, but the parents made a request for a 9-year-old relative who is not the sibling to visit the patient with the purpose of saying goodbye. And we get that request, and then the next layer of that request is that we not explain about the patient's impending death. We only needed to talk about the medical equipment that was happening in his room. And so we talked about the institutional layer. Our CBICU, I'm going to hurry up. I'm going to run through this quickly in the essence of time. We have a sibling visitation policy that states that no one can visit under the age of 18 unless you're a sibling or you live in the household. And there are times when we might be fluid in that and let, people, as long as they live in the house, we'll basically let them visit. And so that policy was in place, and this kind of violated that policy. And the relative was asked if he wanted to go, And we're really not sure of whose decision it was. He kind of looked around and kind of looked at his family members and nodded yes. So we're not really sure whose decision it was. And so I want to talk about the hospital environment. And so the patient, when I talked about the many traumatic complications, he was on ECMO. And as you know, ECMO is a large machine that is filtering blood in and out of your body. I actually can't remember if he had an open chest or not. I think he might have. He was also on dialysis, which is another machine that filters blood. He was intubated. He was sedated. And additionally, he was really at the end of life. His body was starting to ooze in different places, and the skin integrity, his skin was kind of sloughing off, and it didn't really look right. And so there was no way, given the equipment in the room and where it was connected to his body, there was no way that we were going to be able to cover his body. So anybody who visited that room could not avoid seeing the patient in that environment. So we're going to do this really quickly because I want to leave it open for time. Before we get to the assessment portion, I want you guys to use the chat box to share your thoughts on the ethical principles you think are at play in this scenario. What obligations do we have as a child life specialist in this situation? Just all of the dynamics. So what are the things that you guys are thinking about when you think about this situation and what you are going to do next, to what your next action steps would be. So we'll give you just a few seconds or a few minutes to type that stuff in. All right, we've got fidelity, veracity, the best interest of the child who's visiting, Principle 1, welfare of the 9-year-old, trauma of seeing the patient but not understanding. Yeah, these are respecting the family's privacy and wishes. These are all great. So I'm going to keep moving. And so these are the things that I'm thinking about as I am faced with having to make a decision and what I should do. So the patient doesn't really have a role or say, so he's not autonomous. And additionally, we're really unsure as to whether or not the relative was even autonomous, whether that was really his choice or whether that decision was made for him. And then there's also beneficence and non-maleficence, and what does good look like in this situation? And who is the good for? Is it for the patient? Is it for the relative? Is it for the family? And then there's also the intention of doing good. Could it ever become harmful? And when we're thinking about non-maleficence, I'm thinking of, am I mitigating harm by my involvement? Am I intensifying potential harm by removing myself from the situation? So I'm thinking about my personal bias and what I think is right. And so if I decide I don't agree with this, I'm not going to do it, is that intensifying the harm? And really, no action is an action. And that could result in more harm than being involved in the situation. So there's also respect for persons. I had to be really thoughtful about the patient's body and other people seeing him. He wouldn't be able to visit, or he wouldn't be able to be covered for his relative who was visiting. I needed to be respectful of the family's choices, the medical team's choices, and that includes the medical team, the physicians, as well as the nursing staff who were at the bedside. And then there's there's veracity, so telling the truth. So what would I say? I had an obligation to tell the truth to this relative. What would I say if he asked me when the equipment comes out? Or what words am I supposed to use if he asks me if the patient is going to die when he sees all of this equipment? So I had an obligation to tell him the truth. And so in this instance, as Lucy said, we're not necessarily going to always recommend or take action unless we're the ethicist. But I, as the person who, in our sibling visitation policy, we had to clear any sibling who was coming to visit. So as a person who had to decide whether or not this was going to take place, I needed to take action. And so my recommendation was that he not visit, given the nature of the patient's room dynamic, as well as the sibling visitation policy. It was there in black and white. I know sometimes we're lenient, but this seemed a little more extreme than most normal cases. And so I'd like to take this minute to say that sometimes your recommendations won't be listened to. That is what happened in this situation. The family and the medical team decided that this child was going to go back with or without us. And so my colleague was able to prepare him for the equipment and support him through that visit, which was very difficult. And so I'm still able to apply the QAR framework. I made my recommendations, but I can also take action for the future. And so for the future, that might look, taking action for me is providing education to unit leaders about visitation at end of life. It's to the medical teams. It's also working on policy changes in terms of sibling visitation, not only on a regular day-to-day basis, but also at end of life, and how that affects the child-life team, and in our instance, who has to meet with every child who's coming through that door. So final thoughts, so you guys can have some time to ask some questions. This was not a formal ethics case, but more of an ethical dilemma, which I think is really what most child life specialists are going to encounter in their day-to-day practice. I was still able to use the QAR framework to help me take a practical approach to this situation. The recommendation that I made did not pan out the way that I wanted it to, but I do have action steps for the future. And so in facing an ethical dilemma, there are many ways to think through your approach to the situation. And like Lucy said earlier, the QAR is just another tool in your toolbox to pull from whenever you're faced with an ethical dilemma. And so in the nick of time, we're going to open it up. Does anybody have any questions or comments about the case, about the QAR framework? Lucy spoke about the ethics committee. If anybody has any questions, we'll take those. We'll take those now. All right. If there's no questions, we are so glad that you guys participated with us today. This is our contact information. Please feel free to shoot us an email. If you have scenarios or you want to learn more about the QAR framework, just shoot us both an email, and we would be happy to talk through those things with you.
Thank you all so much for joining us today. We really appreciated this time and are humbled to be able to provide this content.
Thanks, everybody.
Lucy and Sarah, thank you so much for presenting today. This was very enjoyable and great to walk through these scenarios, so thanks so much. I'd like to invite everybody